Ray's going to do the second half of the presentation, but we're both delighted to be here along with our colleague Natalie as well on the day our report's published. This has been really good timing. So we're just going to give you a flavour of the findings from the report, and given the conference focuses on innovative practice, we'll highlight some good practice that we've identified as well throughout. A lot of the report does cover both drugs and alcohol, but we've tried to pull out anything particularly relevant around drug services and drug use where we can. And we'll have time for some questions and discussions at the end, but we will be around all day, and as Louise says, we've got a stand at the back as well, so do please come and speak to us throughout the day. And you'll find a report on our website, which is just audit.scot, and you can use it on a mobile-friendly format, so you'll be able to look at the report any point today as well. Unfortunately, we don't print lots of copies of the report anymore, but we do have just a flyer and a summary at the back there. Just quickly, for anyone not familiar with Audit Scotland, we carry out financial and performance audits on public bodies on behalf of the Accounts Commission and the Auditor General for Scotland. This report is a joint report for both, and our work covers around £59 billion of public spending, which is almost covering 300 public sector body accounts, and then just across services, policies and projects that affect all people and communities in Scotland. So just to say a little bit about why we carried out the audit, we've carried out a few shorter pieces of work on drug and alcohol services over the years. We felt this was the right time to carry out a more detailed audit to assess progress since our last update in 2022. I'm sure many of you will be familiar with a lot of these stats on this slide. Drug and alcohol problem use is a national public health issue that disproportionately affects people living in Scotland's most deprived communities. Just a few figures. In 2022-23, almost half of all patients with a drug-related hospital stay lived in the 20% most deprived areas of Scotland. And in 2023, people in the most deprived areas were over 15 times more likely to die of a drug-related cause than those in the least deprived areas, so quite a stark difference. And then just the changing patterns of drug use does make service design and provision quite challenging, I think, at the moment. We're particularly interested in how public money is being spent and whether it delivers value for money and improves outcomes for the people of Scotland. And there has been significant additional investment in drug and alcohol services more recently, and we looked at how this has been directed to address some of the key priorities and challenges. So this just sets out the scope of our audit. Our findings and recommendations of the report are based on evidence that we've gathered through document review, data analysis, interviews with Scottish Government policy leads and a range of national organisations across public and third sector, to better understand local challenges and how they've been addressed. Our fieldwork focused on 3 ADP alcohol and drug partnership areas, which were Clackmannshire and Stirling, Glasgow City and North Ayrshire. And we also engaged with ADP and Integration Joint Board officers in Western Isles as well to get a bit of an understanding of the island context too. We also had face-to-face engagement with people with lived and lived experience of alcohol and drug services through a couple of focus groups, which were facilitated by Glasgow and North Ayrshire ADPs. And Audit Scotland also has a youth advisory group who we engage with about different about our work and different audits, and to kind of find out what's important to young people and get their input as well, and how we share it with that group. So we spoke to them about this audit, and we're actually able to speak to them throughout and about our findings and how we present the report as well, which was really useful, and we'll come on to that in a moment. And it did inform some of our audit questions around how ADPs and schools are engaging with pupils around education on substance misuse. This is a summary of the key messages. There is more detail in the report around this, but the number of people dying in Scotland because of alcohol and drug use remains high compared with other parts of UK and Europe, despite funding for tackling alcohol and drug harm more than doubling over the last 10 years. And we've got some more stats and charts which showing some of the trends in the report as well. So the Scottish Government has made progress in increasing residential rehabilitation capacity, implementing drug treatment standards, increasing minimum unit pricing for alcohol. However, progress has been slow in delivering a range of other key national strategies, such as the Workforce Action Plan, Stigma Action Plan, and also alcohol marketing reform. We have found there's still quite a lot of barriers to accessing and remaining in treatment for people. and those, as I say, already facing disadvantage experience additional barriers, and Ray will come on to this in a bit more detail later. Alcohol and drug services in the workforce are under immense strain, and there's a big focus on treating those in crisis, which leaves limited sort of capacity and investment in prevention. We also found that whole system support for mental health, adequate housing, homelessness, and other services that, wider services to support people, that they are not sort of joined up. They're not all there for people that need them around. Also seeking help around substance use. Annual and short-term funding makes it hard for service providers to plan the long-term and to invest in prevention. And we've also said that the Scottish Government needs to do more around understanding which alcohol and drug services are most cost-effective and which deliver value for money, to be able to sort of prioritise on some of the key areas that are working for people, and to develop a transition plan for how services will be funded when the national mission ends in 2026. So the report's in 3 parts. The first part's focusing on leadership and delivery of national policy, and we set out in that section of the report just the complex landscape of drug and alcohol services and the wide range of stakeholders that are involved across statutory services and also the third sector. And also, obviously there's an important role that families play as well in supporting loved ones with drug and alcohol problems. So ADPs do have a really important role coordinating services, but there are challenges around capacity and how much they can influence how drug and alcohol funding is spent. ADPs can't address the issues of drug and alcohol harm alone, and there needs to be collaborative working with clear and consistent leadership across all sectors. We found barriers to sharing data with NHS and local authority data on different systems, medical records in prisons on separate systems, third sector providers not being able to access information that would help target services, and all that's leading to a lack of joined up working and delays in treatment or getting prescriptions, things like that. And we've got the next slide does show some good practice though around data, and I'll come on to in a moment as well about engagement with young people. The Scottish Government has made £100 million available to support residential rehabilitation placements and capacity, but it's not clear if this will address demand. There's been an increase in placements over the last few years, and Public Health Scotland has reported that the Scottish Government is on track to meet its ambition of having 1,000 people publicly funded to go through rehab per year by 2026. However, the targets aren't based on current or estimated demand, and the need for it is difficult to measure. Many people with problematic alcohol and drug use are unaware of their rights and often feel that they're not entitled to or don't deserve support, and that can prevent access to services. We're aware that Reach Advocacy has worked with ADPs to train staff, but we know that there, around workforce pressures, that there's limited staff availability to do this, and also lack of funding just for that kind of training as well. The National Collaborative is due to launch a Charter of Rights for people affected by substance misuse on 11th of December to help raise awareness and hopefully improve access around rights as well. So this slide is quite busy, but we're just trying to give you a flavour of what's in the report, and you can have a look at it in more detail there. But we did find a few different examples of effective use of data. There's the radar, I'm sure a lot of you are aware of, rapid action drug alerts and response, PHS coordinated early warning system that identifies trends in drug use and increased risk, including the current rise in detecting nitazines. There's Assist, which is a surveillance study of illicit substance toxicity, which is collecting data on the emergence of new drugs or trends in drug use. Through our fieldwork, we also heard about Glasgow City ADP, the intelligence hub that's been set up there, bringing together data and information across services. And also there's a good practice example which we feature in this case study 1 in the report, around near-fatal overdose treatment pathways, which has been developed by Scottish Ambulance Service harm reduction team, and they're supporting outreach work and joining up information and services for people that might not be in touch with services already. Next slide, just again to showcase some good practice, as I mentioned about our youth advisory group. When we spoke to them about this, they identified use of drugs, alcohol and vapes as a major issue for them in schools and their communities. And the young people told us that the way that substance use is addressed in schools is stigmatising and lacks empathy, and the understanding of the underlying reasons for using substance was usually, often not there, so they didn't feel that it was very effective. This engagement with the young people helped direct some of our audit work and our questions in the ADP areas that we did our field work in, and we have found that more work is required in schools to engage with pupils to understand which approaches are most effective in helping young people understand the risks associated with substance use. But we did find good practice in North Ayrshire, which is the one that we showcase in this case study here, and how they're engaging with young people, involving people with lived experience in delivering prevention and education activity in schools, and also developing a directory for support services as well. So I'm just going to hand over to Ray for the second half of the slide and to take you through the key messages and the rest of the report.
Thanks, Jillian. And good morning, everybody. Thank you for having us, inviting us along this morning to speak to you about our report, as Jillian says, that it has just published this very morning. So as Jillian says, in part 2 of the report, what we wanted to do was explore the question of how responsive are services to people's needs. And one of the main areas of focus during our audit, which I suspect probably won't be surprising to many people, was around about how accessible services actually are, both to get into services, but also to stay in treatment once you have engaged in the first place. And what we heard was that many of the barriers that have previously been issues remain significant barriers to people accessing the services that they need, and that those barriers can in particular impact on people who already face significant disadvantage, such as people experiencing homelessness, poverty, poor mental health, and also specific groups for which there are specific barriers, including mothers, young people, and the LGBTQ community. So what we've done in the report, Exhibit 4, as you can see, we set out a range of those barriers that we heard can impact on people accessing services right through their journey from asking for help right through to staying in treatment and recovery. And many of those barriers include the challenge of being stigmatised, being impacted by waiting lists to get access to treatment, experiencing being told they are not unwell enough, not meeting the high eligibility criteria, not being able to access services in their local areas, having to travel further in order to get them, and not being able to access the wider range of services that need, including services such as housing and support for mental health. And we also heard that in terms of the workforce that are delivering all those services, that this is a workforce that is under immense strain, that is experiencing high levels of turnover and can have ongoing issues with vacancies in posts. And all of these things, again, impact on the quality of the service that people experience when engaging. We also did hear that at times the workforce can also be amongst those who stigmatise the very people that they are there to support. So as I said, on that very last point there, what we want to do is we do highlight areas where we see good examples. And when we talk about stigma within the workforce, I thought it was important to highlight this example here of how conversation cafes have had an impact. And in this case, what we heard was that a collaboration between the University of Dundee and the Humanising Healthcare Forum brought together medical students with people with lived and living experience of substance use and addiction. And the impact of that was that it changed the way in which those medical students understood addiction. It changed their preconceived ideas about what that meant, and it helped to kind of break down that stigma that they perhaps already initially had. The impact of that is that those conversation cafes have now been established in the Year 3 curriculum for medical students. And as we mentioned, there are other pilots where we've seen similar impacts, and people who have attended those sessions changing the way they think about and the way they would behave when they engage with people who are struggling with addiction. And then in part 3 of the report, I suppose inevitably we always look at how services are funded. And I suppose the main question that we want to ask was, first of all, was how effective are those funding arrangements? And as we illustrate there at Exhibit 7, what we find is that there's actually still quite a complex funding model for drug and alcohol services. A number of different sources of funding and a number of different avenues through which that investment is distributed and invested in services. What that means is that it becomes more and more difficult to track how that money is being spent, to be able to evaluate how effective different services are, and to understand the totality of the cost of delivering drug and alcohol services. Like many other services, we also heard that short-term funding, annual funding, is hugely problematic, particularly for drug and alcohol services, in particular for third sector organisations, such as not being able to kind of plan strategically for the longer term, and in doing so, not being able to kind of retain that workforce with good long-term job security that allows them to build those relationships with people that are engaging with services which are so important. There we go. So one of the other things we do is we look at how funding has changed over time. And as we set out Exhibit 8, what you can see is that, in fact, there has been a significant increase in the amount of money that's invested in drug and alcohol services, particularly from 2021-22, when we see the impact of the investment through the national mission. But what we also see there, and it's highlighted by that orange line, is that at a local level, in terms of the money that EDPs have to spend, that's actually, in real terms, decreased over the last 2 years as the impacts of inflationary pressures, such as rising staff costs, impact on them. And what that means is that EDPs have, in reality, got slightly less money and having to try and do more with less. As we also illustrate at Exhibit 8, the proportion of funding that goes to EDPs has decreased. If you look back to 2014-15, EDPs received around about 98% of all drug and alcohol funding. That has since decreased. It's now around about 70%. So while still a significant share, it has changed. And as you saw in the earlier slide, that distribution of funding now travels through a number of different courses. For example, the Cora Foundation, we heard, provides a valuable role in being able to get funding out to grassroots third sector organisations that we heard the ADPs would not be as equipped to be able to work with. However, we do recognise that with a wider range of stakeholders and service providers, that does create a risk that funding is not being used in the most cost-effective way, and therefore there needs to be well-managed arrangements to ensure that that funding is well used. So in this report, we highlight a number of the kind of funding challenges. As I've mentioned, having a complex landscape for investment does make it difficult to track and understand exactly how cost-effective services are. We also say that it's important, particularly in this climate where public sector finances are more strained than ever, that it's really, really important that money is used in the most cost-effective way possible. However, what we have found is that data on the cost-effectiveness of services is still lacking, and there is more to be done to understand which services have the biggest impact on people who are accessing those services. We also see that in terms of how funding is spent, particularly from ADPs, this remains mostly focused on those at the greatest risk of harm, and of course that is right that is the case. However, it does mean that there is less money available for those ADPs to be able to transform services, to do things in a different way, or to move towards community-based services and towards prevention as an approach. And finally, in terms of those challenges, there are significant concerns about the sustainability of services. We know the national mission comes to an end in 2026, and as yet it's not clear what will then happen. So for service providers, there is an element of uncertainty about what will happen beyond 2026 and whether those services can continue. So there is a need for some certainty to be established in that respect. Again, just in terms of highlighting an example of good practice, we talked earlier about cost effectiveness and moving towards preventive approaches. We did hear one good example from Glasgow City Council, and in particular from their looked after children's service, and the change in approach that they took, which was to significantly increase the amount of funding that they invested in intensive support to vulnerable families, increasing it from 2.7 to 8.7 million over a period of 8 years. And when they analysed the impact that that had, they found that that had led to a 56% decrease in the number of children going into care, whilst actually delivering savings in terms of the costs of those care placements of 24.6 million and a further 70 million in savings of ongoing costs of keeping children in care. So an example of what can be done in terms of moving towards different approaches and using money in a better way with better outcomes for people impacted by alcohol and drug use. So as Jillian said at the start, setting out some of our key messages. Our report obviously is informative, but we also want it to have an impact as well. So we do set out a number of recommendations in our report, mainly for the Scottish Government, but also for local areas to try and implement as well. And in doing so, and setting out these recommendations, we do say that the Scottish Government needs to increase the amount of focus on alcohol-related harm. The National Mission, obviously, has focused attention a lot on drug harm, but we do recognise there is a need to maintain that focus on alcohol harm as well. But we do say that this should not be at the expense of continuing to keep your eye on the ball and focus on tackling drug-related harm as well. We also recommend that the Scottish Government implement a transition plan so that we can understand and service providers can understand exactly what's going to happen beyond 2026 when the National Mission ends. And we say that the Scottish Government needs to help clarify where accountability sits for drug and alcohol services and those other statutory service providers that are collectively responsible for improving outcomes for people affected by alcohol and drug harm. We also say that the Scottish Government needs to set realistic but ambitious timescales for delivering on the key national strategies. There has been slow progress with some of those, such as the Stigma Action Plan and the Workforce Action Plan, that have an opportunity to have a really very real impact on service, people accessing services. And at a local level, we also say that ADPs, integration authorities and their key partners need to work better to kind of focus on tackling those barriers that I mentioned earlier and that we highlight in part 2 of our report, and to continue to engage with people with lived and living experience to ensure that they continue to inform how services are delivered in the local areas. Going forward, we will continue to discuss our report and its findings with the Scottish Government and with ADPs, and we will in time follow up on the recommendations we made to determine how much progress has been made. I'll pause there and invite Jillian to come back up in case there's any complicated questions. As we mentioned, we do have a stand at the back, and we were more than happy to discuss the report in a little bit more detail with anyone that has any questions. But in the meantime, happy to also take any questions from the floor. Thank you.